So our final speaker is G.R. Thompson, who's my co-chair, who's an associate professor at the University of California at Davis, has a very strong interest in Coccidioidomycosis, of course, and has done great work in that, plus in several other areas in terms of new antifungals and genetic studies as well. G.R.?
Okay, great. So I'm going to just talk about cocci. I know the program said cocci and histo both, but there's been a lot of developments in the field of coccidioidomycosis that I thought it would be important to go over these, including some of the unpublished work so far. Nothing is working. Okay. So the key questions we're going to review is, Dave touched a little bit on this earlier, the expanding geographic range with identification of coccidioidomycosis up in Washington State, which begs the question, what about Oregon? What about Idaho? What about some of these other areas in between? There's been several new diagnostic tests developed recently that are likely to be put into practice in short order. Also, new treatment options and trials. We'll talk a little bit about some of the frustrating clinical problems that we deal with in the care of these patients, and then some of the unanswered questions that hopefully we will finally find the answers to here within the next few years, including the genomic host susceptibility question, other diagnostic modalities, and advances. So just to quickly review the life cycle of Coccidioides, which is pretty important for some of the work that Bridget Barker's doing, which we hope will really illuminate is this saprophytic or sporozoic, what's really the life cycle of this pathogen. In the soil, it's sort of this mycelial phase here. And then grows into higher proportion in periods of high precipitation. And then during a drought, sort of every other cell dies. These are called disjunctor cells, and they sort of act as wings to allow it to stay airborne for a longer duration of time following soil disruption. And this is what is actually breathed in, these little boxcar-shaped arthroconidia or spores. And then these are readily phagocytized by macrophages, neutrophils, and then later enlarge. And that's really what caused disease. And this sort of cycles within the host, of course. And then show you sort of on this slide why that's such a problem. So this is, let's see if this comes up. So this is some experiments we did with our colleagues in bioengineering. These are single cell micropipette procedures. So this is a host neutrophil here, which you can see an endospore from cocci is obviously causes chemotaxis here. And this is a mature neutrophil here, really has no chance. So we published this in PLOS One. I wanted to name the article Cocci Size Matters. The editor did not let us do that, but it was mostly a joke anyway, so we weren't terribly upset about that. One of the interesting things we noticed in these experiments, though, is about 15% of the endospores did not cause any chemotactic response to neutrophils or macrophages, and are relatively inert even if we place them in direct contact as well. So that's an area of active investigation now also. So there have been other major virulence factors identified in cocci, but that seems to really be the major one that we know about at this time. And then so just kind of a quick word on ecology for these organisms. Really what's been proposed is called the grow and blow hypothesis, and that's so year one would be here, and that's a really October, December precipitation. And you see the peak really 2 years later, and it requires this interim drought, which would be sort of August to March. So in California, we've had pretty significant drought conditions for a number of years. These studies have really been quite difficult to predict what year is going to be a bad cocci year. Some people think next year is going to be a very heavy cocci year. It may be, I don't think we have the predictive models really to determine that with great accuracy quite yet. We are entering a heavy season. We've seen a huge uptick in the cocci serology lab just in the last 3 weeks. We've gone up about 10-fold in the number of new positives that we see per week. So we're trying to disseminate that information to clinicians so that they're aware that cocci really is increasing in the community. Seasonal rainfall obviously plays a large role. And with drought, we usually see fires, and usually the firefighters have a big cocci outbreak. We end up taking care of a lot of those patients, even remotely. So some of the firefighters even this year have had a lot of cocci already. So stay tuned. Hopefully in the future, predictive models will more accurately define this. There's some other folks working on sort of airborne detection models using particulate matter, even ones from farm workers, that they'll come and they'll dump their masks out for sort of PCR analysis to see if cocci is in those areas already or not. So what is the natural habitat? I don't think we know that with great certainty. It's been presumed for a long time that it's a saprophytic soil phase, that is, it just eats sort of decaying material. More recently, a group from Mexico, as well as several others, have found a very high rate of seropositivity in some of these mice, and we're not actually allowed to do those studies in the United States. Some of these mice are protected on the near endangered species list, so it's been difficult to do that work. It's also found in high concentrations in their burrows, so that sort of begs the question, is it just a nutrient-rich environment from the rodent feces, or is it actually from the decaying and dead mammals? That's a bit unclear to me. But Cocci, and Joe Heitman showed these the other night, they do lack genes for several of the enzymes necessary for plant cell wall digestion. They don't have cellulases, cutenases, tannases, pectinesterases. So it's been proposed by John Taylor that it may be saprozoic and require really dead and decaying animal matter. And Bridget Barker, who's here, and hopefully will share with us, maybe in our discussion, some of her work looking at Cocci, and is it keratinophilic and it's growing on keratin here in some of her work. So we're really excited to see sort of the results of her studies, see if that will further elucidate really the natural habitat of this organism. So, and then just a quick word on the expanding geographic range that Dave mentioned. It's up here in Washington State, of course, and we've seen positive results from all of these states in the Cocci lab. We've even had a case from Alaska, and an Inuit Eskimo that had never left Alaska, so it's a bit unclear if that was imported through fomites, or really and we don't have the actual isolate from that, so it's a bit unclear, and a lot of these epidemiologic investigations remain ongoing. It's also important to remember some of these are probably transiently endemic, so it's probably transiently endemic in Colorado, and then sort of with a freeze cycle during the winter of each year probably kills off most of the Cocci, and then through wind patterns is again in those locations. And then we talked a little bit about these two rodents that may or may not carry Cocci, and I sort of do wonder if it's a little bit like the hantavirus story, where that precipitation pattern is actually not so dependent on the soil, but it actually increases the mouse population, which is what carries Cocci around. That's just a theory. Nobody knows for sure yet, but there are people actively working on that, and hopefully some answers shortly forthcoming. Oops, did I go too far? So epidemiology, again, we think this is really a tip of the iceberg phenomenon. There's about 150,000 people affected yearly. A half to a third are subclinical infection. They never know they were infected with Cocci. There is almost universal protection from reinfection. There's only been 2 people I know that have had Cocci more than once, and both were laboratory acquired with very high inocula. And you can see here really sort of the time period from 1998 and the number of cases. You see this very large spike in 2011, and the reasons for that are pretty unclear. There's been several hypotheses proposed. One was one of the diagnostic tests may not have the degree of specificity necessary. This may be sort of a false positive increase. Also, the Phoenix area, which is really that county is 2/3 of the Cocci cases, really has seen an explosion in both population and accompanying construction. So that may play a big role in this. And then we've seen sort of a dip with more of an uptick here. So we'll still remaining to be seen what happens in 2016. So, but if you're in the hyper-endemic region, so in Bakersfield or in Tucson or Phoenix, so in those regions, 25% of all community-acquired pneumonia is caused by Cocci. And I really think in those specific regions, if you come in with CAP, you should be tested for Cocci at the same time you're given antibiotics for a presumed bacterial pneumonia. Neither the current Cocci guidelines nor the ATS and IDSA CAP guidelines suggest that. They sort of allude to that to consider Cocci in the new Cocci guidelines by the IDSA. The pneumonia guidelines still don't really say anything at all about Cocci testing unless they have recurrent pneumonia or from an endemic region. But I really think that in those areas, if your pretest probability is 1 in 4, they probably should be tested up front for Cocci. We can talk more about that in the discussion period too. So clues to diagnosis, of course, travel history, or at least an object from the endemic area. There's a patient in China recently that was diagnosed with Coccidioidomycosis. Of course, he did not travel, but he had been sweeping out a cargo container that originated in California, so that was his presumed source. There's been other cases from Jeep wheel wells in Germany during World War II, where the fomite for Cocci in those cases. So travel history is something from the endemic region. Anybody with persistent pneumonia from the endemic region. And then the presence of eosinophilia really is very helpful for identification of Cocci in these patients. And the development of rash, which often happens several weeks later. But the important thing is here, for the people in this room, which I know very few of are actually from California, is 10% of all the Cocci cases are actually diagnosed outside of the endemic region. So it's people that went on a trip to play golf, visit family, or the so-called snowbirders down to Arizona. So these patients are cared for really throughout the country. So important to consider that and to take a full travel history in the care of those patients. So just a few more little background slides. This is really pretty, some old data that we're trying to update. The CDC is really leading the effort here to see really, is this true? Is it really 60% of all infections don't have any symptoms at all and develop lifelong immunity? Or how does this really fall out today? Are we diagnosing more of these patients or less? But if you take 100 people with a new Cocci infection, really 60 of them never had any symptoms, just identified on epidemiologic surveys at a later time. 40 have symptoms which have a tremendous ranging from meningitis and death on one end, really to sort of a subacute course, maybe chronic pneumonia kind of in the middle. And only 2 to 4% progress to dissemination, and 3 to 4% recur and have sort of a relapsing pneumonia. And most of these patients really are diabetic or have some other sort of subtle immunodeficiency. So I spend most of my time really caring for this 2 to 4%. We have a pretty large cohort, probably 400 to 500 patients with dissemination of some type that we follow. And really the question is why? And I think that's really one of the oldest questions in mycology, is why, and we talked a lot about this in the last few days, but why do some of these patients disseminate and others do quite well and never even know they had the infection? The known risk factors are really men develop the infection more often than women. It may be just that men do more with the soil. It's not very clear at this time. Immunosuppressed do very poorly, of course. Anybody with HIV or AIDS, chemotherapy or malignancy, transplant. And I think that that's really an evolving field, as is the TNF alpha blockers. You know, we test these patients for latent tuberculosis before putting them on a TNF alpha blocker or transplant. And I don't think we're quite sure if we should skin test them for Cocci, but with the return of the skin test agent, I think those studies that Janice Blair's now starting up will be really helpful to know if that's a good thing or not. Pregnancy, they do very poorly. Cocci has a estrogen receptor, so it really grows quite well in the presence of estrogen. And then ethnicity, and this is what sort of our work has concentrated on, is why is there this huge genetic predisposition with Filipinos and African Americans in the development of disseminated disease. There's been some papers in the past that suggested Asian and Hispanics may be at slightly greater risk for dissemination compared to Caucasians. I don't think that's probably true. I think that's more of an exposure phenomenon. There's been sort of mixed numbers published in different studies. We don't have a comprehensive database, which is one thing we're hoping to start up in the next few years, is really a comprehensive registry of all patients in California diagnosed with Coccidioidomycosis. But what we do know is some really nice work, mostly from Josh Fear at UC San Diego and the folks at the NIH, concentrating on the mouse models, which has found Dectin-1, toll-like receptors 2, 4, Card9, and then a recent paper looking at MyD88. And then human patients, almost all of them have had a defect within the interferon gamma IL-12 pathway. Most of those patients are phenotypically not normal. They often have Cocci and mycobacterial infections. Talking to Neil Ampel about those. So I don't think that's really what we're used to seeing with these Filipino and African American patients that tend to have just bad Cocci and no other opportunistic infections. So to try to solve this, we looked at our patients, really a targeted analysis of these same regions that had been looked at in the mouse models, as well as Steve Holland's work at the NIH, and we found really nothing. We found that all of our patients in clinic did not have any SNPs within these regions, and that started really a very large-scale effort that's been multi-site. It's gone on now for 7 years. We created a database of over 4,000 patients with Coccidioidomycosis. We had to exclude over 2,000 due to lack of appropriate follow-up. We wanted all of these patients to have at least 2 years of follow-up so we would know if they disseminated or not. All of these patients did receive antifungals. We didn't want that to be a confounder either. So we were finally able to tease all this out. All of the patients are immunocompetent, do not transplant, not on any medications, not HIV positive. They're all adults and non-pregnant. All were treated with a fluconazole or some other triazole. The cases we defined as anybody with dissemination, and they had to have proven disease, either by culture positivity or histopathology. And then the controls are people that did well, and they were mostly proven or probable disease in that group, since people that do generally pretty well with just pulmonary Cocci don't undergo invasive procedures. And they had to have no evidence of dissemination after 2 years off therapy. So this took us a long time to gather up all these patients. We have DNA that's been sent to the Broad Institute, and supported by them and the NIH. in conjunction, and we were really hopeful we'd have this wrapped up by this meeting, but I think we still have just a little bit more work to do. So hopefully we'll have the answer to this. Extremely hopeful, since it took 7 years to do all of this, that we don't need more patients and that we're appropriately powered to really answer this, because I think that would allow us to do a lot of things in the future, such as screen patients. The prison system has a huge problem with Cocci, and if we could screen these patients genetically before taking them out of a non-endemic region and putting them right in an area of hyperendemicity, we could avoid exposure for these patients as well. So diagnostics, of course, culture is definitive, laboratory hazard, don't open anything that's a white mold. Histopathology, characteristic forms in tissue. Here's sort of a spheral emptying. It's endospores. You can see how it's very quickly logarithmic growth. It's not really a one-to-one like Cryptococcus. It's spheral to several thousand endospores. Here's histopathology with an empty spherule. Serology really remains the mainstay of diagnosis, immunodiffusion and complement fixation, although there's EIA tests as well. We'll talk a little bit about this number, this more than 1 to 16, and suggestive of disseminated infection in a couple slides. And then alternative methods we've looked at just a bit as well. So we published this a couple years ago looking at 1,3-beta-D-glucan, and David Stevens and Dimo Papagiannis have looked at this in the spinal fluid more recently. But we were curious, say a patient in Massachusetts that had been in Arizona or California, something else, that was going to have to wait on a send-out test, is looking at a beta-glucan someplace that might do them in-house, able to give them a little quicker push that this may be Cocci. And so we found that it had a pretty, just like most of the beta-glucan studies, it had a pretty good negative predictive value, but really the sensitivity depended on sort of the burden of disease. So, pretty low sensitivity depending on sort of if it had acute Cocci or more sort of substantial, usually these patients with other hospitals with Cocci have symptoms for a couple weeks at least. So it showed some utility and not quite what we were hoping for. Another problem we run into a lot is these patients with pneumonia and lymphocytic pleural effusions. And California is one of the regions that also has a very high incidence of tuberculosis. So tuberculosis and Cocci both come up in the care of these patients, and it had been written in the literature previously that Cocci had positive ADA levels, although no data had ever been presented with that. So we decided to look at our cohort of patients with pleural pulmonary disease if ADA could be helpful to either differentiate TB, or if it just served as a confounder and it still was not able to differentiate TB from Cocci for us. And we found very fortunately that this did not muddy the water. If they had a high ADA, they did not have Cocci. So it can be sort of a helpful test if it's already done, which it often has been at the time we're consulted as infectious disease physicians. So just something to keep maybe in the back of your mind for that as well. So, okay, so that's sort of, I think a lot of you all know those aspects, but we'll get into sort of the newer things now. So the antigen test has been around for a few years, but I think the publications are really starting to show the utility of the antigen testing, which is available at Mira Vista. I think when you order this test, there's two things you have to consider first, and that's really the timing of disease and the host. So in a highly immunocompromised patient, the antigen test might be helpful. If it's very acute disease and you think too soon to have a positive serologic response, that's probably an appropriate patient to order an antigen as well. And then in the spinal fluid, and I think that's where there's a lot of questions still. There's been, I think, just 7 patients reported in this most recent study, and it does show some diagnostic utility in those. I think it would be helpful to have patients that sort of followed longitudinally in larger numbers. It may really be helpful in those who have like intrathecal amphotericin, who can develop a chemical arachnoiditis, which can really alter your interpretation of the spinal fluid white count protein and sort of confound the picture. Serology from the spinal fluid, the half-life of IgG is 3 weeks. So if you have something that changes more rapidly than that, that can really be a pretty helpful test. A lot of these patients develop severe complications and need neurosurgical intervention, which also confounds our ability to interpret the CSF profile. Antigen might be useful in that group as well. So I think we need more studies to look at this, but I think as one of the new kids on the block, it sort of is a helpful adjunct to current modalities in the diagnostic and care of these patients. Okay, so we just finished this just a few weeks ago, really the development of a lateral flow assay for Cocci. There's, one of the main complaints we hear in the serology lab is there's a long delay in the turnaround time for serologic samples. That's actually not a factor in the reference lab. It's, FedEx sort of cohort samples until they have a financially reasonable number to send to an outside lab. So if there's a lateral flow assay that's clinically available, this can be done in rapid turnaround time. It's simple to use. really doesn't need reagents, and we're hopeful that this will allow for just a yes or no answer while the patient's in urgent care, the ER, or in clinic. You can see here sort of the example. It's sort of different than the cryptolateral flow, so you need blood on both aspects. There's a control line and then sort of a positive line for if you have IgM alone, IgG alone, and this particular sample is positive for both IgM and IgG. So we're really hopeful that that's going to be helpful to some of our patients in speeding up the time to diagnosis. We still don't know that treating these patients with primary disease is a big, makes too big a difference in the long term, but it certainly may reduce the number of inappropriate antibiotics they're prescribed. It may reduce the number of times they have to be seen in follow-up for sort of no one knows what they have. So one other thing we've worked on recently is this immunosignature. And so this really is kind of a newer technology. It's a pattern of antibodies, which allows for a pathogen-specific signature. And so the way these are made on the chips is they're not made with cocci-antigens. They're made with just random amino acid peptide profiles. So you can put blood in, the pattern should be able to tell if they have dengue, and they've worked on brucella. They have one for cancer diagnostics as well. So, but what we were able to do with this one, just in the preliminary stages of investigation, is tell us this Posidoceae or immitis, really by their profile. We don't know that that's useful clinically. I mean, it's useful epidemiologically, particularly in some of these areas where there's overlap between the species. And this really pained me as an internist to write this. The advantage is not hypothesis-driven. I mean, I would get so mad at our med students if they said, no, not hypothesis-driven research. But I think that that's probably helpful to people. If this was commercially available and could be used in the ER, and there was also a database that had pneumococcus and respiratory viruses and all these other things, and you're able to do an immunosignature just right then as a point-of-care test or within a few hours, I think that really would be a pretty helpful test and may not need to be hypothesis-driven. You wouldn't actually have to consider their entire travel history, which I don't think the ER takes that often, because it does have the ability to detect multiple different pathogens. So there's a lot of questions for this. How does this profile change over time in sequential samples? The work in brucella, they actually can use these immunosignatures to predict who develops different complications of disease, and that's something we're hoping to do with cocci, is be able to predict who's going to disseminate really at their time of diagnosis. But how is this test going to work in the immunosuppressed patients? We may not be able to do that. And how does this test work in co-infections? I think that's really a long way away to have this kind of technology available in a clinically, with a quick turnaround time. So, okay, so that's sort of the background on diagnostics and some of the other things. The next few slides really are what I spend most of my time dealing with our patients. Treatment guidelines, again, for cocci and primary pulmonary pneumonia. We don't know that treatment actually benefits most of these patients, and there's really a lot of unsettled arguments about this. We do know we should treat anybody that's immunosuppressed. Almost all patients with diabetes are treated. They have a much higher propensity to develop chronic pulmonary infection. Anyone who's frail due to comorbidities or age is what's in the new guidelines. I don't know how to define that anymore. Age, I think that offends too many people. And then this is also a pretty big debate. So a lot of people treat everybody if they're Filipino or African American, but the important point to remember is treatment does not prevent dissemination. It probably just delays it, whereas when you stop treatment at a later date, they will disseminate at some point after that. And then exceptionally severe primary infection, which I think is also variably defined by different practitioners. Really, all of those patients should be treated. But they do acknowledge this as an unsettled issue due to a lack of prospective clinical trials. So here's sort of the background for why that is. Some people call this the California and Arizona camp. I don't think that's totally true. There's people in California that don't treat everybody, and then vice versa for Arizona. Those who really argue to treat everybody say not treating is historical and based when amphotericin B was the only option. They say it may decrease the intensity or duration of symptoms, but there's a question mark there. That may prevent chronic disease. I don't agree with that. And then there's a group that says not to treat, and they say there's meds the patient may not need. We see a lot of fluconazole toxicity in our clinic at the doses we use for cocci. Alopecia is the biggest one. We presented some of that data. We really tried to look at the mechanism of alopecia in our patients on fluconazole. Fluconazole is a CYP26 inhibitor, which is the same pathway for retinoic acid. Retinoic acid causes alopecia as well. We looked at an animal model of alopecia, so we fed these rats fluconazole for months and months at a time until they started to lose their hair, which was good because then we didn't have to redo the experiment. And looked at their retinoic acid levels, retinol esters, and retinoid compounds, and really found that that's probably not true. So that hypothesis had been proposed back after Pete Pappas's Annals of Internal Medicine article that noticed alopecia, one of the letters to the editor, and it's really sort of persisted in the literature since that time. But we found in the rat model and our human cohort model that retinoic acid, their levels are normal. So what to do with that, I don't know. It may be an intracellular effect or something else, but just as sort of an aside, I don't think it's retinoic acid as toxicity from fluconazole as a cause of alopecia. So back to this, not to treat, they also say 95% of patients resolve their infection no matter what you do, and that's sort of the older literature as well. But the good news is really thanks to the efforts of the CDC and conversations that stem back probably 5 or 6 years when we wrote a small trial that has since evolved into a very large study, NIH-funded prospective study, and so it's going to enroll just patients in the endemic region with CAP. And that's, again, sort of leveraging this 25% of patients that actually have cocci rather than bacterial pneumonia. And they're going to randomize these patients 1-to-1. They'll get either antibiotics, which is defined as placebo in their sort of flowchart, or antibiotics plus fluconazole, and then sort of follow these patients over time. And the primary endpoint really will be symptoms at day 21 of therapy to see if really we help these patients. They have less fever, they have less chills, less arthralgias. And the secondary endpoint will be symptoms at day 42. And the good thing is we also have a very large sample collection repository. It's going to collect patient DNA. There'll be saliva, serum, urine from these. So they'll be available for development of new diagnostic tests as well, and hoping to make prognostic tests in the future also. So that study has only enrolled about 35 patients so far that I know of. There's people in the room that probably, I think, are on the DRC and probably know a little bit more about that than we do. We haven't received any of the sera for these patients yet, so I know enrollment is maybe going slower, but with the recent uptick in cocci cases, like I mentioned, we're hopeful that that will begin to increase very soon. So one of the things that's come up recently that makes me sort of pause in the management of this is in collaboration with the fungus testing lab, we asked them to pull all of their cocci samples that had been sent there for susceptibility testing, which was more than 400 isolates. And interestingly, more than a third of the isolates had fluconazole MICs more than 16. So I think that we know from clinical care that these patients should have high-dose fluconazole, but a great big study looking at susceptibility had really not been performed in the past. And this shows one of the problems with really the primary pulmonary studies are using low-dose fluconazole at 400 a day. So up to a third of these patients may not have drug levels that are thought to be effective. We can argue, do these even predict outcome with cocci? I don't think we know that for sure. We don't know that in vitro MICs actually have a clinical correlation for cocci patients. We did find 22 isolates with fluconazole MICs more than 64. And those really had a variable MIC to other mold-active triazoles. MICs more than 2 are pretty rare, which you can see here at the side. One of the other really interesting things we found is the echinocandin susceptibility. We thought for a long time, these are not particularly useful drugs for cocci. There's been some animal models that do show probably some benefit in combination. These should never really be used as monotherapy. And then in CID just a few years ago, there were 2 articles published in the same issue that both showed these as adjunctive therapy may be beneficial as well. So you can see this tremendous range in susceptibility for echinocandins. So what to do with that, I don't think we really know quite yet. There are problems with this, of course. It may be biased. Patients with primary pulmonary cocci probably are not going to have isolates sent for susceptibility testing, so there may be some bias to that. But David Stevens' animal models have really shown that fluconazole is not as effective on a straight milligram per milligram basis compared to the other azoles. And we have one clinical trial comparing ITRA to flu that showed ITRA was better for bone disease. And that's how that study has always been interpreted. We've checked itraconazole bone levels on patients. They've always been 0. So I sort of interpret that study more that itraconazole is just a better cocci drug. Patients with osseous disease probably have a very insufficient response than those compared with pulmonary disease. It wasn't really powered to show superiority, but I do think, just from anecdotal experience, I think really all of these are better drugs than fluconazole for people with severe cocci infections. If you have primary pulmonary disease, again, it may not matter if you treat them at all, but if you use fluconazole, you probably do need to use a higher dose. So one of the other problems that's come up in recent years is we noticed this phenomenon where patients that had symptoms and sought care very quickly and received antifungals, they never developed IgG antibodies. And so we did this sort of case control study here And there's a precedent for this type of phenomenon to abrogate the immune response in Lyme disease, so that's patients treated very early don't develop positive Lyme serologies. Same thing for syphilis. If they come in with a syphilitic lesion and are treated, sometimes they don't develop a positive RPR. Sort of a similar phenomenon with streptococcal pharyngitis to treat them with penicillin and to sort of avoid antibody that will cross-react with the valves. So we sort of looked at this and grew up Cocci under different concentrations of fluconazole. And you can see here it's sort of concentrations you see in people between 16 and 128. The CTS1, which is the target, it's a chitinase. It's the target for IgG antibody that we test for in the lab. You can see it really diminishes sort of an off-target effect of fluconazole here. And then looking at this sort of in our clinical study, that really was the only thing that sort of we saw as a difference between those who developed an IgG antibody and those who did not, is if you had very early treatment with fluconazole. So we do think this is a pretty rare phenomenon. It's not common that patients that seek care that quickly after the development of symptoms, and even fewer are put on fluconazole that early. So I don't think this is going to affect the results from the clinical trial. But what does trouble me from that is sort of Janice Blair's publication from just a few years ago. And if you look at this was just a prospective observational study of patients with primary pulmonary cocci. You can see, and so let's see, the dotted line is those who were treated with fluconazole, and the solid lines are those who were not. And these are really sort of the 9 most common symptoms you see in primary pulmonary cocci. So fatigue, night sweats, chills, cough, headache, chest pain, arthralgias, and rash. And you can see those who were treated at about 20 weeks, a lot of those had an uptick in their symptoms, sort of these late compared to the non-treated patients. These are not statistically significant, but this is clinically what a lot of us have seen, and it's problematic because around this time is when we often start talking about taking patients off therapy. So this is a pretty big confounder when we take care of these. So is this a question, have we altered the immune response by fluconazole? We showed sort of the differences that might happen serologically. That's actually how we got interested in retinoic acid is fluconazole changes retinoic acid metabolism inside lymphocytes. So we wondered if maybe they didn't respond as well if they were on therapy. We don't have all that data quite finished up. But this is sort of a confounder to me, particularly the arthralgias. Is that really just fluconazole or is that a patient immune response? I don't think we know still, but hopefully one of the questions we will answer with this larger prospective study sponsored by the NIH, as this was underpowered. So one other problem that comes up a lot in the care of these patients, and I would really just encourage the audience, I know everybody here sees probably the occasional case of cocci, is to do this backwards from most of the pneumonia cases, right? So most of the community-acquired pneumonia cases, we get a chest x-ray at some point in the future to make sure they didn't have underlying malignancy. Well, the cocci cases we like to follow to resolution because we want to see how it healed. So these little granulomas, this can avoid an oncology workup 30 or 40 years in the future. So we often will print these out and give them to the patient and tell them this is not lung cancer. Don't let people take this out. It avoids a surgery in 30 or 40 years. So that's to it. But I was sort of traditionally taught anybody with a titer more than 1 to 16 gets an LP and a bone scan. It doesn't matter if they're complaining of symptoms or not. And I really didn't like that. So we made sort of a multi-center collaboration. This is retrospective data. But we used the same criteria that had been published in the New England Journal for when does this patient need a CT before they have a spinal tap. So we used those same neurologic parameters when we did this retrospective study. And what we really found was if these patients with cocci, it didn't matter what their their complement fixation titer was. If they had no neurologic symptoms, they just didn't have meningitis. So we've been fortunate that's really avoided a lot of lumbar punctures, even with patients with high titers. You can see here the titers don't overlap quite as nicely as they did sort of historically. There's patients with CNS infection with low titers, 1 to 4, so that's an important point to remember. It can be sequestered disease. You can have a serum titer of 1 to 4 and a CSF titer of 1 to 512. They don't always go together. And then patients with no CNS infection had very high titers on occasion as well. This has been sort of reflected in the new guidelines that just came out a few weeks ago to really do a symptom-based approach to diagnostic workup for these patients, and sort of there's some statements against bone scans for everybody as well, which I think is really helpful and avoids unnested testing for a lot of these patients. So if they have no neurologic symptoms, really routine lumbar puncture is unnecessary. So the problem that comes up is you saw the patients with primary disease, a lot of them have headache. So that's a neurologic symptom, and that can be difficult to tease out. Do they really need a lumbar puncture or not? As a chronic meningitis, often you can see them back just a few days later if they don't have any other obvious manifestations of CNS disease, and sort of try to avoid it in that fashion too. But we're very glad that this came out to really avoid lumbar punctures for a lot of the patients that come in. Okay, so just a few more comments, and this is really focused on meningitis, which is what I think I spend most of my time in Cocci dealing with. And so the severe consequences of meningitis really are stroke, hydrocephalus, and space-occupying lesions. This is really some nice work that David Stevens did, looking at sort of the different cytokines in a rabbit model, and then also some human studies. And really, these are all suppressed by corticosteroids. You can see here in the rabbit model, really the normal vertebral artery, and then mild inflammation by day 4, severe inflammation by day 9. This is really all a neutrophilic process around the artery. This is not like a mold infection where you see invasive growth through the arterial wall. This is different than that. So with the same consortium that we had sort of evaluated these lumbar puncture rules, we were able to come up with a pretty large number of Cocci patients with meningitis, 221. And of those 221 patients with meningitis, 8% had a vasculitic infarct at some point. And we define that as any infarct during the acute care of their Cocci meningitis. And we were curious about, do steroids help this or not? So that's always been really a debate in the field. Obviously, they're immunosuppressive with someone with fungal meningitis. Is that helpful or harmful? So you can see on the left side here, patients that did not have a stroke, which were 203 patients, there really was a trend towards a lower opening pressure, fewer white blood cells, a lower protein, and a higher glucose compared to those who did have a stroke. So we think this was a higher burden of infection as well. This was all before the antigen test was available, and antigen testing has still not been correlated quite with the burden of infection, so work that needs to be done as well. So these were all just a trend. We saw a lot more inflammation in those who did have a stroke. Sort of interestingly, those who do have strokes are almost always Hispanic and Caucasian. The Filipino and African Americans tend to come in with meningitis light. They have headache and the symptoms, but they're not obtunded as frequently as Hispanic and Caucasians. I think that would be hopefully answered in the genetic question, which I think will be polygenetic. But again, sort of gets back at this question of too much inflammation, too little inflammation, or just the right amount. So what we found is the patients who received corticosteroids after a stroke, only one had a second stroke, and those who did not, all 3 continued to have strokes throughout their care. And this was highly statistically significant at 0.0049, an odds ratio of 0.01. But the problem is, since it was a retrospective study, there were a variety of corticosteroid regimens used. People use dexamethasone, people use hydrocortisone. We'll never do this prospectively, obviously. It's just not common enough of a diagnosis to do. And so we're hoping to send this out really just in the next few weeks, but hopefully helpful for you in the care of your patients. This was safe. Only a few complications of corticosteroid use, which were hyperglycemia. One patient had AV necrosis of the tibia, which I'd actually never seen. And then one was superimposed bacterial infection as sequelae from corticosteroid use. And so this is really the last slide. So just a brief comment on new agents. I know it's been a long day, but isavuconazole, really the new kid on the block of the triazoles, a mold-active triazole. There's clinical data now for primary pulmonary cocci. We don't have any for disseminated infection, which are higher burden, require obviously a longer duration of therapy. We're hoping to do that within the next few years, but really need some mouse model data first. The clinical trials are planned. This is an Astellas compound. Nicomycin Z, just a quick question. That drug's been around in the literature for a long time. Chitinase inhibitor, prior animal studies were very encouraging. It's a cidal agent. Toxicity has not been seen in preclinical studies. Manufacturing this drug is actually pretty difficult, but phase 2 trials are planned and hopefully be conducted within the next year. This drug's owned by the University of Arizona. And then a Viomet compound, which I don't think is in the public domain. If it is, it's not easy to find. But it's a CYP51 inhibitor. It's been given an orphan drug designation for Cocci. It does have an oral formulation, so we're hopeful to see sort of the phase 2 studies that are planned for that in the near future as well. So really, the conclusions for Cocci, there's an expanding area of endemicity. I think we'll continue to see that with the investigations that are ongoing in Oregon, Idaho, Montana, Colorado, some of these other areas. Travel really has increased the number of these patients seen by practitioners outside the endemic region. There's a number of new diagnostic tools. Lateral flow assay will be out pretty soon. There's a new EIA test. We still need to learn a lot more about the antigen test. And then new treatment options are urgently needed for this disease. A lot of these patients end up on lifelong therapy. There is toxicity with azoles at the doses we use. And And so hopefully we'll have new agents available for that. We'll be able to answer this question about does primary therapy of cocci help? I'm not sure we're going to get an answer for that for a lot of reasons we can talk about later. And then there are a lot of unanswered questions, which I'm very hopeful we'll have an answer for in the next few months, and that's really the host factors responsible for dissemination in these patients, new diagnostic modalities, and what really is the best agent. I think anecdotally, a lot of us think that the mold-active triazoles are the best, but we don't have animal data that definitively shows that, and we certainly don't have a clinical trial that shows that. And so with that, I'd like to thank really the members of my lab here in Davis, as well as collaborators. Jane Sykes has been just a wonderful colleague to work with, as has Angie Gelly. TGen has been just a lot of fun to work with on the studies such as that Dave showed today. CDC, which has really kind of led the charge in the fight against this infection. And then Emmy, Sean certainly has been really helpful in developing this lateral flow assay. And then the NIH and Broad and the genetics work that we're hopeful is completed quite soon. So thank you so much for your attention. That's sort of the end of this session. I think we have a short break and then back, or?
Back at 4 o'clock.
Back at 4 o'clock. So, okay, well, thank you all for your attention. I'll see you soon.